Hi, everyone. We want to welcome everyone to this panel tonight and take a few moments to introduce ourselves and share what you can expect from tonight. We're really thrilled that BRYT has given us this opportunity to put on this event. For those of you who aren't familiar, BRYT, or the Bridge for Resilient Youth in Transition, is a part of the Brookline Center for Community Mental Health. And BRYT helps schools across Massachusetts and beyond build and maintain really high quality re-entry programs for students returning to school after a medical or mental health crisis. There are hundreds of these re-entry programs across the state in elementary schools, middle and high schools. Our BRYT Family Engagement Team, myself, Lindsay Yamaguchi, Megan Harding, Kara Briley, Sue Donofrio, and Caitlin Robichon provide resources and facilitate virtual parent-to-parent groups. They're free and open to all caregivers. And we run these groups, and we started running them in the spring because we want caregivers to know that you are not alone. So if you're interested in joining our mailing list for these groups and other events, please feel free to share your email in the chat, and we'll make sure to keep you posted on any upcoming events. Since last spring, we've really had the great fortune to meet so many amazing caregivers through these groups. And most recently, we've heard from both parents and school clinicians that there's an increased need for crisis supports and services for students. Specifically, we've noticed an increase of students in crisis, and by crisis, we mean an experience when a student is at risk of harm and isn't able to guarantee their safety. It's our hope tonight that this panel can help families and clinicians better understand and access these systems, and that we can all work together to keep our kids healthy and safe, especially now as we're all learning together how these systems might be operating differently during COVID. We are so grateful to have a panel of experts who work every day with kids and teens in various crisis systems. They'll each speak briefly about their work and experiences during COVID, and then there'll be lots of time for questions and answers. But throughout the panel, please feel free to put your questions and thoughts in the chat, and we'll be monitoring those. And without further ado, I'd like to introduce Jen McLean. She works in mobile crisis. She's been working in the field of mental health for over 15 years, with more than 8 of those years dedicated to crisis work. She's currently the site director for Advocates Psychiatric Emergency Services in Burlington, Massachusetts. Advocates is a community-based emergency services team providing mobile crisis intervention to 31 towns in the Metro West area of Massachusetts. Thank you so much, Jen, for joining us.
Yes, thank you so much for having me. Again, my name is Jen. I am the director here of the crisis team in the Burlington area of Massachusetts. And what we do is provide crisis support, intervention, and resources to anyone who lives in the cities and towns that we work in. And though Advocates might not be your local crisis team, this service is offered to any city and town in Massachusetts. We have individuals, teachers, schools, parents, youth call up and ask us questions, ask us for support, call us when they're having a bad day. And it can be, the service we provide can be something as simple as a phone call, or the primary function is when someone is really struggling and having a tough time is doing an evaluation. And that is typically meeting with individuals wherever they're at, whether they're at school or home, in the community. We can be with them wherever they are and help them through that tough time. When should parents call our service? Whenever they feel like they need support. We are open 24 hours a day, 7 days a week, whether it's Christmas or 4th of July, we are here and available. And if you have a simple question about who might be offering services in the area or need a little support on the phone, we are available to you. So really parents can call whenever they need support or whenever they feel that their child might need intervention. What to expect when I say evaluation, I know that can be a very loaded question. You might already have some thoughts, but what that means to me and what that means to us is that we would sit down with the youth, with your teenager, your child, and chat with them about what's going on. Some of the questions that we typically ask, tell me what brings you in today. Tell me why you're here. Who referred you? What are some of the concerns? Tell me a little bit about yourself. Tell me about your family. We gather a history of the things that are going on, the symptoms. So if they are depressed, tell me about that. When did that start? We grab information about their treatment history. If they have been in a program before, what did that look like? Was that helpful for you? Was that not helpful? And most importantly, what's going on today? How are you feeling today? The number one priority of my job is to assess safety for individuals. And so making sure that they are feeling safe, that they are not having thoughts to hurt themselves, to hurt other people, and really taking a deep dive into that. We like to call it a risk assessment and talking that through. We also typically ask for collateral information. So that means reaching out to a therapist or reaching out to a social worker at school, making sure that not only are we talking to the youth, but we're also talking to their parents. We come in and we have the ability to meet with individuals for an hour. And we really need to get a big understanding of what that big picture looks like. And the providers in that child's life are the ones who can give us the most detail and see lots of things. So we do reach out to collaterals to obtain information about what's going on and what they're noticing. And then together as a family, as an individual, and the provider who's conducting the assessment, we make a plan. And we make a plan for, can we be safe? Do we need additional support? What do we think would be useful? Sometimes it's even, what are you willing to engage in? What kinds of things have worked for you in the past and what can we do moving forward? So those are some of the things that parents and youth can expect to be asked and to have talked about during an evaluation with our team. What should parents do or advocate for when you come in? What are some things, those things I can't forget to ask this or make sure I do that. And my biggest piece of advice is to ask questions, to tell us to slow down and explain what we're talking about. The field of mental health is confusing and is changing every day. And when you're in the midst of a crisis or your child is having a really tough day, it can be fast-paced and scary, and things can go by at such a daunting speed that we can sometimes get lost in it. And I know even for me, I'm human. I talk fast. I use acronyms. I want to be able to get these young people the support they need as soon as I can. And I rattle off things. And sometimes the biggest thing that parents can do is say, wait a second, I don't understand. What's a CBAT? Can you explain that to me? What does a day look like there? Can I see my child when they're there? Things like that. So just asking the questions, slowing down, and really talking it through. And then, everything that we do is kept strictly confidential. We do not, I know I had said before that we reach out to therapists and providers to gain information. we don't give out information. So for example, if we're seeing little Jane Doe at school, because she had made some concerning statements to her school counselor, it doesn't mean that we're going to go and provide that school counselor all the dirty details of what was said during that evaluation. So everything is kept strictly confidential, unless, of course, we're concerned for her safety, or that it's something that's approved by the family or guardian. So that's a little snapshot of what we do here at the Mobile Crisis Team in Massachusetts.
Thank you so much, Jen. Next, we have Alex Feliciano. Alex is a crisis clinician at the Wheeler Clinic in Connecticut, offering immediate crisis response to children and youth ages 3 to 17. She has her bachelor's in social work from Central Connecticut State University and her master's in social work from Smith College. She's trained in numerous therapeutic interventions, including CBT, DBT, narrative therapy, trauma-informed therapy, and play therapy. Thank you, Alex.
So hi, my name is Alex, and I'm a crisis clinician at Wheeler Clinic in Connecticut. And so very similar to kind of what Jen had explained, I kind of will just talk about a little bit about what we do. It is almost exactly the same as the Massachusetts Crisis Team. So basically, the mobile crisis service is accessible to all parents and families, and we offer immediate crisis response. So immediate meaning within 45 minutes of the crisis call, we are, responding out to the home or to the community, wherever the child is located at that time. And we kind of just provide response to behavioral emergencies. So behavioral emergencies look very different for, every family and every child. So that may look like, physical, verbal aggression, suicidal, homicidal, depression, anxiety, just basically essentially any mental health concern that the family or school or child, may be experiencing at the time. And mobile crisis is essentially a diversion program for the emergency room. So instead of kind of taking your child to the emergency department to get evaluated, a crisis clinician comes out, to the home or the community to do an assessment, to kind of assess for safety, assess for risk. And that's essentially what mobile crisis does. Just like a brief explanation of what it does. So parents should contact mobile crisis whenever they are concerned that their child is in a crisis, and it could be anything kind of what I kind of just mentioned. So it could be behavioral concerns or just safety concerns that a parent is unable to maintain safety for the child. And a crisis clinician can, safety plan and do a risk assessment to make sure that the child is safe. And then also another thing that mobile crisis kind of offers is non-mobile support. So that is just, a phone call offering the family or the child or whoever is kind of calling, kind of support and guidance, and even offering referrals, via the phone. So we can, also do that. And then also crisis clinician does assess like the mental status of the child, like I said, so safety and risk as well. And then parents should also just kind of call mobile crisis if they're not connected to therapeutic services. So we're also kind of we bridge services to help families get connected to services long-term. So we do call ourselves like short-term therapeutic services until you are connected to more longer-term treatment. And so we're, able to do that and connect with with the families until they're with a longer provider, like for longer term. So parents should kind of just expect clinicians to stabilize the current crisis that's kind of happening in the moment. And that could look, very different from, it just depends if it's the child's experiencing, if it's behavioral concerns, kind of coming up with ways and coping skills and ideas to help the, family and child kind of regulate and help the child kind of come back to like a baseline and for them to kind of be stable. And then after that, a crisis clinician completes like a full assessment. And assessment is, Jen kind of explained it, it's just a ton of information collected to kind of get to know the child and family better, to better connect them to services and programs. And so, the questions can be regarding a child's medication history, treatment history, demographics, a family history of mental health, and just kind of collecting a ton of information so we can better, support the child and the family when we are like, researching and kind of looking up different programs and stuff that can be better for the family and the child. And then also we just collaborate with the families to kind of come up with a safety plan that would help the child, de-escalate or not become escalated again. So once we leave, there's a safety plan that gets put in place that consists of coping skills, different supports that the child can kind of reach out to if he is feeling or she's feeling escalated. And yeah, so just kind of preventing a crisis from occurring again. And those are, so sometimes the assessment, I forgot to mention, assessment can be completed with just the child, giving the child, privacy and like ability to kind of express themselves and talk like more privately, or it could be with the family as well, or both. Just giving the child more of that support rather than having like the family kind of intervene and, talking, over the child. Sometimes the children or, adolescents also just want that privacy to express themselves better, communicate better. So they also can do that. So parents should ask for as much as information as possible when kind of meeting with the crisis clinician, especially about the next steps that are kind of going to occur, including what, who are you going to collaborate with, who are you going to speak to, and just asking as much question as possible, because it is a, calling mobile crisis, it's scary to begin with. It's, it is a complicated thing. Sometimes parents are hesitant to call. They don't really know what to expect. So definitely just ask a ton of questions regarding, the next steps, like what's going to happen next, what do I have to do as a parent? Do I have to follow up with anyone? It just ask like a lot of questions regarding even, mental health, like, what is my child experiencing? How do I control them? What can I do to help their behaviors? What can I do to manage it? Just ask, a lot of questions, because, mobile crisis is there to help and support and kind of guide the family to kind of help them with, mental health in general. So, and then also I would say that parents and families should ask mobile crisis to advocate for them. I know sometimes it's not, completely feasible, and we are a short-term program, but definitely ask either if it's, school that's they're kind of struggling with, just asking mobile crisis to advocate for, an IEP or 504 or any services that they may need in the school. Definitely ask mobile crisis to be that, that voice and that advocate for you, because I know that can also be scary and challenging, and not really knowing, the rights as a parent, or the rights that your child has in school, or, the rights that they have in general regarding their mental health. So definitely just ask questions regarding that. So then after the assessment is completed, mobile crisis does offer, or they do conduct a follow-up phone call. So they're basically just checking in, obtaining any updates that the child may be experiencing, like behavioral wise. Are they, getting better, or are they still kind of, de-escalate, or are they still escalated? And then they also provide the families with their own follow-ups. So their own follow-ups could just be like, depending on if they already spoke to the other providers and collaborated with other providers, kind of reporting to the family the next steps that are going to happen. And then after that follow-up phone call, crisis clinicians do offer follow-ups. So basically it's just like a short-term, therapy sessions. And it's, once a week, and they meet with either the child by themselves or with the family, just depending on what the family needs and what are their needs at the moment. So they do kind of conduct that in bridge services. So we are like just a short-term bridging services, giving the families what they need, the support, the guidance, and anything else that, they may need until they are connected to the longer term. So there are follow-ups that crisis clinicians, do offer, just depending on the severity of, the cases. We do assess cases based off like low risk, moderate risk, and high risk, and just depending, that's how frequent we kind of go see the families and see the child. And we also do daily check-ins if needed. So there's a lot of support that you will receive from mobile crisis when you do contact them. And so then the last thing is with confidentiality and privacy. So just like kind of Jen said, that everything is confidential. Your privacy is, the most important thing for us. And we do collaborate with other providers. And sometimes if it is necessary, we will disclose certain things, but obviously with the permission of the parents. In the family, we do have, release of information that you have to sign for us to provide that information. So you will always know when we're gonna kind of be talking about your child or your family with someone else. But only the necessary information pertaining to your child will be disclosed. Nothing that it's personal to the family, or some things that the families might say like, no, I don't want that to be disclosed to the schools, definitely will be kept confidential and private. And we just contact, like the PCP or schools or other therapists or other providers that the child may be connected to already, just to kind of come up with a better idea and collaborate on what better services the child may need. And then we also just give out information to other agencies. So if we think that the child may benefit from a specific service or program, we do, with your permission, give that information out to the other services and programs just to get them connected, almost like an intake. And then just like regarding like the stigma of mental health, I know that it can be very challenging and very like overwhelming, and mental health in general is such a broad like topic, and so there could be so many different things with that. So we do help the families kind of navigate the system of mental health and support them and guide them through different things, and provide them psychoeducation and knowledge regarding mental health and what their rights are, and what they can expect from us. And yeah, so that's pretty much everything about mobile crisis. And I am from Connecticut, so it might be a little bit different. And the easiest way to contact mobile crisis is just calling through 211. If you are in the Connecticut area, just call 211 and you'll get connected with a crisis clinician.
Thanks so much, Alex. Moving on to ER, the emergency room department. Dr. Caitlin Wilds is a board certified psychiatrist, currently finishing up her last year of subspecialty training fellowship in child and adolescent psychiatry at UMass. She graduated from the University of Texas with a Bachelor of Science in Neurobiology in 2012 and graduated from Texas A&M University's Medical School in 2016, prior to moving to Massachusetts to pursue her graduate specialty training in psychiatry. She currently works in many areas of both adult and child psychiatry, including UMass, CHL outpatient psychiatry and therapy, inpatient, child, adolescents, and adult psychiatry. She's also worked at the CBAT and ICBAT level of care with addiction services, both inpatient and outpatient, for children, adolescents, and adults. Welcome, Dr. Wilds.
Hi, thanks so much. So unsurprisingly, the emergency mental health system is pretty similar in the ER as it is through mobile crisis. We do a lot of the same evaluation, but I think what's different is the fact that you have to come to the ER and we can't come to you. So what it looks like when you walk in the doors is a little bit different in COVID than it was in non-COVID times. So this is also probably going to go back to the way it was at some point, we hope. But right now, all of the kids will come in through triage, or just like the main emergency room entrance. Once you check in at the counter, somebody will bring you and your child back to the pediatric emergency department. So within our ER, if anybody's ever been to UMass, this is the one right by the lake on 55 Lake Ave North. They have a separate pediatric ER, a separate emergency mental health ER, and then the main adult medical ERs, which are divided, I think, into 3 or 4 different pods now. So when you go back onto the pediatric emergency side, you'll see an ER doctor there and an ER nurse, and they'll ask you the basic questions. I think this is a general theme, and I actually walked through this with one of my patients. You're going to ask the same questions probably about 10 times. So just kind of be prepared for that level of frustration. Each person has a checklist that they're doing. In addition to wanting to help, they all have to enter stuff into the computer, unfortunately. So that's just a nice frustration to be aware of. They'll probably sit you out in the hallway too, as opposed to giving you a room, just because their space is limited, and because they're handling a lot of the mental health overflow right now, they're putting us in the hall as opposed to people who are needing like procedures who go into rooms. So once you've checked in with the emergency doctor, they'll ask you about physical complaints and just make sure that were you to go into a psychiatric hospital or a psychiatric facility, your physical health is okay. So this is kind of getting like a nice checkbox. And this is the point in time where you will get a COVID test as well. Everyone gets a COVID test. Kind of unavoidable at this point. We're mostly doing the shallow nasal swab, so it's not the brain biopsy anymore, thank goodness. And we're also not asking you to spit like an entire day's worth of saliva into a tube. For the most part, we were allowing people to come over to the emergency mental health side at this point up until really recently. So a lot of people have run into this testing with COVID, but if you haven't, there's a rapid and a PCR. So most places were just running COVID rapid tests and not waiting for PCR results to come back. However, this kind of like bit us in the butt a few months ago, and we had 3 kids return positive PCR results after negative rapids, thereby exposing different facilities to the virus. So because of that, the new protocol in place is that you have to wait over in pediatric ED, like the medical part of the ED, until your negative PCR comes back. And then you can go over into emergency mental health. Within emergency mental health, there is an adult and a pediatric side. So at no point during this process are you ever with psychiatrically mentally unwell adults, which is nice for our kids. The interesting part that's different with COVID than it was before the pandemic is when you see a mental health clinician. So we have people who do basically exactly what Youth Mobile Crisis does. It's a social worker or a mental health specialist, and they come over into the medical emergency department now most of the time because that PCR takes a while to come back. So instead of just waiting there, the clinician will come over and see you. That can mean the evaluation is sometimes done in like a waiting room area, or sometimes even like in a hallway bed. Ideally, if our patients have a room, that's where we do it, but that's not always a luxury. This is probably like one of my biggest areas of frustration because it doesn't allow for as much privacy as it had in the past. But I think we're all, trying to do our best. And if there is a room available, we'll certainly use it, but just something to be aware of too, that everyone does respect your privacy and we care so much and we're really trying our best. But during the pandemic, like the space is it's really limited. So I think as long as you have that in mind, that's kind of helpful and just what to expect. So once the social worker or a mental health counselor meets with you guys, they'll usually meet with the parent and kid first. They'll meet with the parent alone and then meet with the kid alone. During this time, like mobile crisis, they can also contact collaterals. So if the parent wants the kid's therapist called or the kid's psychiatrist or the school, then we can kind of tag them in and see what their take is on the situation that led to you guys presenting to crisis. From there, the goal is really disposition. So like it's been talked about before, we have a few different levels of care. The least restrictive, obviously, is just going back home. And from the emergency department, we can also have Youth Mobile Crisis follow up with you guys at home. So if you're going home, usually you end up with a Youth Mobile Crisis follow-up and a safety plan that you guys complete together with the clinician in the emergency room. The next level up from that is a partial hospitalization program or an intensive outpatient program. These used to be all in person. I usually call it psych day camp to the kids because it's about 9 to 3 and you get to sleep at home. And the programs usually run for about a week or 2. So this is like a good option if you're needing more intensive support, but not at a hospital level of care. So right now we're actually doing a mix of online partials and in-person partials. And partials are a little bit interesting because how we refer also depends on what kind of insurance you have. Unfortunately, that's just another thing that we kind of have to deal with. And oftentimes our outpatient wait lists just to get like a therapist or a psychiatrist appointment are much longer than the partial wait lists. So for example, like in my outpatient clinic, our wait list is currently around 4 to 6 months, which is not super duper helpful at all if you're in the middle of a crisis. So having a partial in our back pocket is a nice way to get you outpatient support where you can still sleep at home, but you can usually get into a partial within a week. So that time frame is obviously a lot better than 4 to 6 months. And then from the partial, people get referred to outpatient services. And then once they see that you've had one of these like crisis stabilization services, like a partial, you are more likely to get off the wait list quicker than if you just sought it by yourself. A step up from partial or intensive outpatient is a CBAT, and CBAT stands for community-based acute treatment, and then ICBAT is intensive community-based acute treatment. So these are kind of a halfway between partials and full inpatient locked secure units. The kid does stay there at night. The doors are locked, but the parent has the full rights to remove the kid at any point, which is different than an inpatient unit. They're actually under more of a school jurisdiction than a hospital jurisdiction, and jurisdiction is not the right word, but I'm not going to remember the right legal term for that. So basically CBAT and ICBAT is at a facility, but it's not locked. And it's locked for the kid, but not really locked for the parent. It's an easy way to put it. The difference from CBAT to ICBAT is how often you see the psychiatrist. So with CBAT, the psychiatrist will see the kid about once a week. And with ICBAT, it's every day. Most kids step down from ICBAT to CBAT after being there for a few days, and they'll do medication management, therapy group, and then also set you guys up with providers in the community. Obviously, a step up from CBAT, ICBAT is the locked inpatient unit, which is a type of psychiatric facility. It will be a specialized unit with kids. They'll be seen by a psychiatrist every day. And in addition to groups therapy, the difference between CBAT and ICBAT is it is locked. So your child will be there on a legal section. So probably you've heard the term like section 12 or section 1011. So kids can't sign themselves in voluntarily until they're 16. So a parent would need to sign a conditional voluntary, and this can also be foster parent, guardian, DCF, whoever has custody of the kiddo. And sometimes parents will be in a disagreement with this decision, and that's probably the toughest part of my job. And then we have to send them over on a section 12 if we feel that they're at such a risk to themselves or to somebody else that we don't feel comfortable sending them back home. Most of the time, everybody's in agreement with this other than the kid. I've never had a kid really want to go into the hospital, but the parent and the physician are 99% of the time on the same page. So when that happens, it's more intensive, but the average length of stay is also shorter. So it's usually about a week. And then as with all of these things, when you go from the highest, usually they step down levels of care. So from inpatient, you can go to CBAT, ICBAT. From there, we can refer you to a partial, and from there, you can get outpatient resources. So that's just kind of a brief overview of what you should expect in terms of disposition when you come into emergency mental health. And I'm happy to ask or answer any additional questions and follow up.
Thank you. And last but not least, we have Rachel Friedman. Rachel's a licensed mental health counselor specializing in adolescent mental health. She received her master's degree in mental health counseling and behavioral medicine from Boston University's School of Medicine in 2017 and has been working at North Shore Medical Center since then. She's currently a clinician at the Adolescent Partial Hospital Program, doing both group and individual therapy with middle and high school students, and also working with teenagers in a private practice outside of the hospital. Thanks for being here, Rachel.
Yeah, absolutely, my pleasure. And Dr. Wilds gave a really nice overview of what partials are, so I apologize for being redundant a little bit, but I'll add a little bit more detail. So partial is essentially a highly structured voluntary day treatment program. And we provide really intensive, really short-term treatment and support for adolescents with emotional difficulties and also their families during, but more after times of acute crises. So the type of treatment that we provide is similar to that of an inpatient unit, actually, which is a comprehensive psychiatric evaluation, individual group therapy, medication evaluation and monitoring, and then also family support, but in a much less restrictive setting. So our unit's not locked, and everything we're doing right now is via Zoom, so that would be weird if it was. We basically are psych day camp. I really love that, Dr. Wilds. I'm probably going to steal that, so I appreciate it. And our partial is also insurance-based, and we serve adolescents from ages 13 to 18. We have a multidisciplinary team of therapists, LMHCs, which is what I am, my license type, licensed social workers, psychiatrists, nurse practitioners, psychologists who all provide care. Really, our ultimate goal is stabilization and then also increasing our team's capacity to cope with the life stressors that usually brought them to us through skills training or process-based work. We'll also provide case management. That looks like working with schools. We love the BRYT program. We work with them all the time. We work with other school reentry programs. We also do discharge and aftercare planning. Pre-pandemic, we were in person. Unfortunately, everything we're doing right now is virtual, which is a little bit different. Our program hours are 10 to 3, and our average length of stay, or our average time that kids are in treatment with us, is 8 to 10 days, like Dr. Wild said, so, and a week and a half to 2 weeks. I think the biggest difference between the previous crisis services that you had heard from and a partial program is that if your child is in acute crisis, you should not call us, because we are not the service who is going to come evaluate you and see you immediately. That would be something like the crisis team, the emergency department, even 911. Usually kids get to us through those different services. So crisis or the ER or triage will refer to us. Parents can refer to us as well, but typically, at least for our partial, we'll often ask that your child is evaluated by another service before coming to us so that we can get a bigger picture of what's really going on. If you feel like your child might need a partial level of care, that would look like if they had a significant mental illness and you notice really worsening symptoms. So significantly impacting your child's functioning, whether it's at school, whether in social circles or at home with family, etc. And then what you should expect when you first come to us, again, things are a little bit different because we're virtual, but once we receive a referral from one of the other services that I mentioned, that we can also be referred from outpatient providers, even schools, PCPs, primary care physicians, whoever can refer to us. We'll receive that referral. Our patient service coordinator will reach out to you. We'll schedule an intake, and the intake is with a clinician like myself, and then a member of our medication team, which is a psychiatric nurse practitioner or our attending psychiatrist. And our intakes are about an hour or so, again, taking place via Zoom. We'll ask you a ton of questions, ask your child a ton of questions. It'll seem really redundant and invasive, and I apologize if you've ever experienced that before, but really it's to get a better understanding of what's bringing your child to treatment and mostly how our program can best support them in their time of need. So we ask, again, the same things that actually Jen had mentioned. What brings you to us? Symptom onset, history of psychiatric treatment, current and former providers, medical history, a whole lot of questions, academic performance. We'll also do a risk assessment or assess for current safety concerns. But again, if your child is in an acute safety concern or in an acute crisis, we will actually send them to the emergency department or have a crisis team evaluate them. And let's see, I'll give you kind of an overview of what a typical day at partial would look like, or a typical time in partial. So kids attend our program every day, Monday through Friday, similar to school. Majority of the work that they're going to do is in a group setting with other teenagers who are struggling with pretty similar issues, which in and of itself is really cathartic and therapeutic when teens can relate to each other. Our partial has 4 groups during the day. 2 are kind of like a community meeting, 1 in the morning and afternoon. We'll check in with our kids, see how their evening was, briefly discuss any challenges or stressors that came up, and then have them set an intention for the day. We'll do the same thing in the afternoon, reflect on the day, set an intention or goal for the evening. In the middle of those 2 groups, we have 2 skills intensive groups where we'll work on building things like emotion regulation strategies, frustration tolerance, communication, mindfulness skills, all the things that teens and everybody else during the pandemic and before really struggling with. And we'll also do things like working on managing unhelpful thoughts, more general strategies for mental illnesses like depression and anxiety. We have process-based groups. Kids can come to us and say what they want to talk about, whether it's family issues, peer relationships, school concerns. And then we have expressive and art therapy groups, which will look a little bit different via Zoom, but we can still do them, which is awesome. And then in between the groups, our adolescents will meet with their assigned clinician for individual work, which complements that group-based work. And while the kids are in treatment, we'll have at minimum 1 family meeting where we'll talk about what it looks like while they're in treatment, what we're doing, what we're working on, discuss how things have been going at home, address specific concerns, and then discuss aftercare planning. In terms of follow-up, we're again a little bit different than crisis services, and this might be specific to North Shore Medical Center, but our partial, once a patient discharges from us, we don't have contact anymore because we are no longer the primary providers, but we do our best, that's part of our case management work, to really make sure that all of our patients have appointments with outpatient providers in place before they discharge just like Dr. Wild said, actually, we'll make referrals to other agencies as needed, other outpatient providers or whoever, and then work with schools to facilitate that transition. Privacy is also paramount for us. As you would imagine, everything is confidential, discussed in groups and individually. It remains between the patient and clinician and treatment team, aside from any of those safety concerns that I had mentioned before, at risk to hurt themselves or others. All of our paperwork and our session notes live in our electronic medical records system. It's a hospital-based program. We don't share information with any outside providers or any other systems of care unless a caregiver gives its explicit consent or signs release of information. That was a really broad, I threw a lot of information, so I'm also happy to answer any other questions about partial level of care.
Thank you so much to all our panelists. I have been in this field for a long time and I learned some new things tonight too. So I really appreciate all the info that you've shared with us and sort of what's changed a little bit during this COVID time. And now we want to open it up to Q&A, and a couple of our BRYT Family Engagement Team members, Sue and Caitlin, have been monitoring the questions. So I'm going to pass it over to them to read off some of the questions that have come through.
Thank you, Lindsay. So no questions yet. There is a slight delay with the streaming, so we'll give that a moment. But as we've been talking and I've been hearing more about the information, this is really helpful for me because as a program leader, and I think this is something that we hear a lot, is when should families, and I guess this is a question for Alex and Jen, is when should families call mobile youth crisis and when should they go right to the ER? Follow-up question to that is it different now through the pandemic? Is it more, is the process smoother to go one way or the other? Obviously, if there's a safety issue, maybe the emergency room is, or calling 911 is right where you want to go. But for students who are maybe being screened at school and being recommended for an evaluation, is there a certain recommendation right now during the pandemic that would help families know how to get help more quickly?
So I guess I can start, and I think Alex and I might have very similar things to say. But I mean, I always encourage parents to call their local mobile crisis team first before going to the emergency room. Potentially, run the situation by that provider. If there is imminent danger, if they are concerned that their child is going to hurt themselves in that moment, or the child is acting aggressively, or the parents feel threatened or in danger themselves, then yes, they should be going to the emergency room and probably even calling 911. It would never, if the situation is out of control, would never recommend a parent be putting themselves or their child at risk by transporting a child in a car to an emergency room. And there have been numerous times where when you're in that moment, sometimes it's really hard to know what to do. Give a call. We'll always direct parents with the most appropriate, we'll often have clinicians say, it sounds right. Like right now we need to go to an ER for safety, for containment, so that, the child can calm down and meet with a clinician and be safely monitored there. And as far as I know, in Massachusetts, and specifically for the team that I work for, things are a little bit different right now with the pandemic, and it's not something that I had talked about before. Right now, as the mobile crisis team, we are doing a lot of things over Zoom and over telehealth. So we also, as the state of Connecticut, and Alex had said, we do have a 45-minute window to meet up with families and individuals. Fortunately, the ability of telehealth has allowed us to do that much faster, not having to hop in your car and drive over. But it also prevents a barrier that we are over this platform that we are right now. It's serves a great and wonderful purpose, but it doesn't allow you to be face to face with someone. Hopefully the vaccine and, the decline in numbers will change that soon, and we'll be mobiling out. But I guess the answer to the question that Sue, you had asked is, my recommendation would always be, if there is an imminent danger, if there is an out of control situation, calling 911, going to the emergency room. And if you're having trouble wondering when that is, call the crisis team and ask. Always ask.
And from there, if the student is recommended for inpatient, does mobile youth crisis always call and find them a bed, or would they then be referred to the emergency room? Does that vary through different crisis agencies?
So if the evaluation that is performed does result in a child or adolescent needing an inpatient placement, ooh, that's such a tricky question. Right now, it's very difficult to place a youth into an inpatient facility without an ER visit. Can it happen? Yes. It's very tough. Often young people need medical clearance, and you might say, but they're 13, they're healthy, they have no problems, this is that. We need to know that medications are okay. And like Dr. Wiles had said, that medically they're okay. There isn't an alternate reason that a medical reason that this child might be experiencing some of the things that they're experiencing. And COVID testing, unfortunately, it's a sign of the times, and it's a necessity to get into a lot of these places. Dr. Wiles had spoken to, the fact that it's dangerous out there with the pandemic. We don't want your child exposed to a sickness. We don't want other children in placements exposed to a sickness. So often, yes, and kiddos do need to be medically cleared through an emergency room in order to obtain an inpatient level of care. And quite frankly, when we are referring, I take placing a young person in an inpatient facility very seriously. It's never my ultimate goal to put a child in a hospital. I want that to be the last, most extreme thing that I do. And I often call people like Rachel and other outpatient providers to refer to partial, like let's go up the steps rather than down the steps. So, it's definitely not our, top priority to do that. But when there is a safety risk, often the emergency room can be that contained environment for these young people as well. Yeah.
Thank you. We have a question. Should students engage in school while attending PHPs, or should they hold off entirely and wait until discharge from the program?
I'm smiling because I have such terrible answers for parents about this, because I know a lot of them want me to say that they should continue working on homework. And on some level, I do think that that's true. But unfortunately, I don't have a blanket answer for you, because it is highly dependent on the level of functioning and ability of the individual child, and also what school says necessarily. So we have some kids who come to our program and school is actually an outlet for them. So we say that when you are done with partial, absolutely, you can work on some schoolwork as long as it does not contribute to or significantly impact your mental health during that time. We have other kids who come to us because of school avoidance, anxiety, refusal, unfortunately bullying issues that have taken place, and school is really triggering. So we actually have to work on stabilizing and then slowly exposing to school prior to even thinking about homework. So it truly depends on what the patient is coming to us for, their background and their level of functioning. We do work really closely with schools. So again, I mentioned we work with the BRYT program before. So when kids are in our program, as long as we get parental consent, we can reach out to guidance counselors and adjustment counselors, let that academic team know that their student is with us, and all of that missed time in classes is excused. There can't be any real penalty, especially in public schools, or particularly in public schools, for engaging in medically necessary treatment. Same thing, we'll work with trying to reduce the workload or prioritizing certain assignments. That's where BRYT really comes into play with us. So yeah, I didn't give a satisfactory answer, but I forewarned you that I would not, so I feel okay about that. it's really going to be pretty dependent on the different types of kids and what they're going through.
Thank you so much. That was actually really helpful. And I also want to thank everyone because this has been so insightful for me as a clinician, and it's great information for all of our parents to hear. I had one parent that couldn't come tonight, but had asked me to ask a question for her. And she had a question about discharge planning and what to do if your child has been seen by the psychiatrist and been put on medications, and then the goal of discharge is to then continue with an outside psychiatrist and to continue with outside therapy, but appointments haven't been set up yet, or they're put on a wait list that takes longer than the dose that they've been given. And how should they navigate that? And how should they deal with their anxiety of having their child discharged, whether it's from a partial or an inpatient program, without all the services set up that they need?
I can take this
I
one.
assume that that's for partial. Okay, good.
Oh, either way, I work on a lot of inpatient units in the CMAT ICBAT, so I can speak to like what we do in those instances, and then maybe you can cover like what the partial does, although I bet it's unfortunately really similar. So we endeavor to have everyone have an appointment. I don't personally believe in ever discharging somebody without an appointment to see a psychiatrist and a therapist, because otherwise you do get into this really dangerous zone of like, if you're on a wait list and you run out of medication, we're kind of back to square one, or potentially back to square one. So what we do in my practice is we make sure you have the appointments, and then I write 2-week supplies with refills. So I don't like to give kids who have recently like been hospitalized or in a placement a month's supply of medication that they can potentially overdose on right out of the hospital. So I give it in 2-week supply. So it'll look like, 14 days, and then with, 3, 4, 5 refills, like however long it takes to get to that appointment. Sometimes you can get into hot water if that appointment needs to get rescheduled. And in that case, it's always going to be following up with that outpatient provider. Once you've left the hospital, it is almost impossible to get a hold of the physician that you worked with at the hospital. And it's especially impossible for us to keep up with all the refills for the kids in the hospital. And then, if we tried to follow up with all the kids who discharged from the hospital, that would just be way too much. So if for some reason that happens, make sure you call the intake clinic of where you're being referred outpatient as soon as you know. And oftentimes, like I work outpatient also, I'll do like a one-time emergency bridging prescription. And this kind of rare instance too, sometimes the patient's pediatrician or primary care doctor can provide that bridging prescription. And I would say like my biggest advice is just try to keep that appointment, try not to get discharged without an appointment and without script in hand or at the pharmacy with enough medication to get you to that appointment. And if something happens, just let people know in as far advance as you can, and make sure you're communicating with the new outpatient doc.
Thank you. Dr. Wilds, a question that I have, you talked about getting the negative PCR test. Recently I had a student who was waiting in the ER for over 24 hours. So just knowing how long the COVID tests take to come back. So what is sort of an expectation of how long someone might wait in the ER if they are waiting for an inpatient bed right now?
That is an unfortunately great question. So the PCR tests are taking about 24 hours to come back. That could get pushed out even farther if the hospital has an influx of tests that they have to get through. So I've seen probably the maximum time is 72 hours for the PCR. In terms of waiting for a bed, this is unfortunately just insanely dicey right now. So kids in the ER are waiting days or weeks at this point for an inpatient psychiatric bed. This is the case also from the medical side. So like a kid who was seen and admitted medically and then needs a psychiatric placement, it's the same for them. And I've actually seen it take up to over a month for kids with medical issues to get placed, because there are very, very few inpatient child psych beds who can also do medical issues. So if your kid has something like diabetes, you're going to be waiting much longer than if your kid doesn't have any kind of medical conditions. I would say the average wait time for an inpatient bed right now is probably 3 to 7 days, but that varies at any given point. If you can, don't go to the emergency department on a Friday. There are no discharges that take place over the weekend for inpatient psychiatric hospitals, for the, like, generally speaking, which means that there will be much fewer beds available. Most places try to fill up on Friday morning. And so Monday afternoon, evening is really the best time to go, because the attending physicians are back in the hospitals. They're starting to discharge patients again. They're knowing what their bed situation looks like for the week. So it's always better to go towards the beginning of the week than the end of the week if you're looking for a shorter stay.
Thank you. And can you talk about what that 3 to 7 days would look like for a parent? They'd be able to stay with their child, but what kind of things would be happening there for them?
Yeah, so if you're waiting, there are a few different places you can wait. If you're waiting for an inpatient bed, it's going to be either pediatric emergency mental health or the pediatric medical ER if we're full over in pediatric emergency mental health, or you don't have your COVID test. Parents can be with you 24/7. The kids sleep there. They have, like, in pediatric emergency mental health, it's like a living room with chalkboards, TV, couches, a table, chairs. And then they have like a male and female sleeping room with some chair beds in it. Unfortunately, like, for parents, it's not good accommodations at all. A lot of parents tend to go home at night and then come back in the morning so they don't sleep on either the floor or snuggle in the chair bed with the kid. Kind of the same for the medical ED. They can either sit in a chair, kind of snuggle in bed with the kiddo. Sorry, you asked one more question. I forgot what it was.
Just sorry, can you hear me? Just what the family might be doing during that time that they're waiting for they're waiting for their child to find a bed.
Okay, so nothing is the large and short of it. It's a lot of downtime, and we don't have any electronics allowed over in emergency mental health. So that gets pretty tedious, lots of watching TV, coloring. And for that reason, like, as you can tell, probably it gets really unnerving for the kids really quickly. It also doesn't have any windows in that room. So if we can have them wait at home, we do. Unfortunately, if we're saying that the child needs to go to inpatient psych, we can't have them wait at home, because what we're saying is this kid is too dangerous to be at home, and sending them home is in direct contradiction to that. So then when we're trying to ask the insurance company to pay for it, they're going to say no, because we're essentially saying this kid is safe enough to be home, but we want you to pay for them to not be home, which they don't like to do. So this is the area where we try to do a diversion to a CBAT or ICBAT if at all possible, since that's a locked facility for the kid, just not locked, for the parent. CBAT, ICBAT does afford you the ability to wait at home in a lot of instances. And while you're waiting at home, Youth Mobile Crisis can also follow up. And so we can actually continue the bed search for CBAT, ICBAT while the kid's at home. So I try to do that if at all possible, if a kid is needing to sleep somewhere and if the parent feels safe with the plan.
Thank you. That is very helpful. Can you just clarify the difference between a CBAT and an ICBAT?
Yep. So the one that I worked at was Wetzel, and it's the same. Both programs are in the same building. The kids are mixed. The only difference is how often you see a psychiatrist. So with the CBAT kids, we meet with them usually once a week for psychiatry. And for the ICBAT kids, we meet with them daily. And most ICBAT kids will eventually step down to CBAT. So the real core treatment of a CBAT and an ICBAT is groups, therapy, and then family therapy, which they'll do with a clinician kind of supported supervision. And for us, the med piece with ICBAT kids is a lot more present. So we'll see kids who are like more severely psychiatrically ill on a daily basis. And then once we get them stabilized on a medication, we'll say, okay, they can step down to CBAT, which is really just kind of an insurance definition. So insurance will only pay for a certain number of days for ICBAT or a certain number of days for CBAT. So we try to get them stepped down once they're medically stabilized. That being said, if any of my CBAT kids ever needed to be seen for medication issues or wanted to check in or were having trouble sleeping, it's easy to pop in and see them. So I would say it mainly seems like an insurance distinction, but from a practical standpoint, it's how often you see the psychiatrist.
Great, thank you. That's really helpful to know. So a follow-up question is and this could be for any of you, what advice do you have for families in regards to like telling siblings what's going on or telling a grandparent what's going on, so that way, younger siblings or even older siblings aren't feeling panicked, but they know what's going on and what to expect? Because I have a lot of families struggling with how to talk to family members once their child's in crisis and needs services.
Boy, we're just all silent. I can speak a little bit to this, and it relates back to maybe a pre-question about navigating the stigma around mental health. I think it is really, really important for families, if this is kind of the rules that are set up in the home, obviously, and this is your communication style, but to have open communication and have an open dialogue about what is going on. Because very often what we have heard from younger siblings of our own patients is that it is way scarier to not know and to just hear from a parent, yes, X, Y, and Z, your brother Sam is in the hospital, but without any real context for it. And if we kind of open up the conversation about maybe why they're in the hospital, just like you would if Sam broke his leg or God forbid he had some other kind of acute illness, cancer or whatever the case is, you would have a pretty frank conversation about that, I would imagine, with a younger child. So if you are trying to decrease the stigma and open up mental health to be on par with physical health, which I think everybody on this panel would agree that it is, having kind of an open conversation, obviously with some safer language, would be my best advice for you. I'm not sure if I answered the question.
That's very helpful. And then, so I know you mentioned that there are family service aspects or family therapy aspects in the CBATs or the ICBATs, but is that part of partials and inpatients as well? That the family is included in the whole process in family therapy?
I can speak from partial, and again, it's just North Shore Medical Center's partial. We don't do family therapy in the traditional sense. We have what's called a family meeting or a family session, which is really to orient everybody who's in the home environment into things that have been going on, what we are working on in partial, how their child is doing, really clue the caregiver in a very intensive way. But we don't necessarily do family therapy. If we have patients who come into our program, and often this is the case, we feel like would benefit from family therapy, I'm a huge proponent of family therapy, we'll refer out. There is, of course, a very long wait list for all agencies involved, but often that would be our recommendation, more so than trying to delve in. And one of the reasons is that your child is with us for maybe 7 days. Family therapy is very intensive, it's very emotional, it needs ongoing support. It is not something that would be safe for us to open up in the short amount of time that you are with us. And if we were to have a family meeting, it would, which we do, it's about an hour, and an hour is not an appropriate length of time to do a family therapy session and then say goodbye, we're not going to see you anymore. On an inpatient unit, it might be a little bit different. Dr. Wild can probably speak to it. On our inpatient unit, it's similar. They'll do a family meeting, maybe with a little bit more of a therapeutic aspect depending on the length of stay, but it wouldn't be family therapy in the traditional sense in an outpatient setting.
Yeah, so on inpatient, it's exactly like that. It's more of a family meeting, family planning, like how can we make the house safe? How can we avoid triggers and working on the safety plan? At the CBATs and ICBATs, it's actual family therapy. So because the length of stay there is a little bit longer, like closer to 2 weeks, sometimes 3, and it's a little bit more flexible, it will be the kid, the clinician, and we try to have like every family member that's involved in the kid's life in a family session. So if the parents are divorced, our goal would be to have them both be in there together if it can be at all civil. If not, then we have to do it separately. But the clinician and the kid will have a number of these family therapy sessions throughout the stay. And the goal is really, it's not to, open up like really deep trauma wounds or to process like, deep psychological grief. The goal of these family therapy sessions is more kind of cognitive behavioral therapy. So what is the parent doing that's hurting the kid? What's the kid doing that's hurting the parent? What are our thoughts and feelings around this? And then what are some behaviors that maybe we can do individually and together to make this a better situation? So it's kind of more superficial family therapy than it would be like with an outpatient, either psychiatrist or therapist that you guys would know on a weekly basis. But it is, I think, what I've seen, like one of the corner building blocks of what makes CBAT like a lot more helpful than an inpatient stay, because these parents are like really getting to know like, oh, this is how my kid thinks about this problem, and this is how I'm contributing to it, and I wasn't seeing it like that. And then making real changes within the house to prevent a crisis situation from happening again.
So we'll give people a few more minutes to ask questions in the chat. I like the points about what families can expect for the partials. Is there things that families can do at home to support their student while they're undergoing treatment, whatever level that might be? So participating in the family therapy and the treatment and collaterals, but is there something that families could do at home to help support their child just day to day while they're going through the treatment?
This is a semi-unpopular opinion whenever I bring it up to parents, but I always recommend that everyone's in their own therapy. If their kid is struggling, chances are the parent is struggling, the siblings are struggling. The house is not a wonderful, happy environment 24/7, although no one's really is. But having a kid suffer is probably one of the most difficult things a parent can ever go through, and having someone where you can just kind of like unload, that you meet with once a week, where you don't have to like watch what you're saying, you don't have to say it in a certain way, you're not protecting the kid, the sibling, your spouse, is incredibly necessary, I think, throughout this whole process. And having happy-ish, high-functioning parents who are able to like demonstrate like, hey, going to therapy is normal, seeing a psychiatrist is normal, this is like, how we handle grief, stress, anxiety, like mom gets overwhelmed too, and the whole family is showing that that's normal to work on. I think that's when I've seen families be like, by and large, the most successful. So A, the kid's not feeling alone, and B, everyone's getting a nice outlet that's not their family members to vent and process with.
Thank you. I've heard, and families have heard a lot about, at least for partial specifically, that a lot of the work that their children are doing is group work, and not as much individual work. So can you speak to how like their day looks, and if it is just more group therapy based, or if they get both the individual and group aspect of treatment?
It's both, but I guess, majority of work that our kids will do is in a group setting. So pre-pandemic, we had, oh man, it's been so long that I don't remember. That's embarrassing. I think we had 2 or 3 45-minute groups in the morning. We would have lunch. Pre-pandemic, we worked in a block for academics, where kids would work on schoolwork provided by schools independently. So we didn't provide any sort of tutoring services, but it was more of autonomous, self-initiated work. And then 2 or 3, and I apologize, I genuinely can't remember at the moment, 45-minute groups in the afternoon. So we would start at 9 and end at 3. So it's about 6 hours during the day, including lunch and academics. And then in between those groups, or actually during those groups, a clinician could pull their patient out of the group and complement the group work with more individual therapy. So our groups are a little bit more broad because all of our kids are together. And again, as I mentioned, we work on things like emotion regulation, distress tolerance, a whole host of different issues that our teenagers are struggling with. Individually, we're meeting our patients' more specific needs. So it could be that they just had a frustration tolerance group, and that is something that they are really struggling with. We'll reinforce that individually. It's never groups alone, and it's never individual alone. It's always together. They complement each other. But for sure, kids are spending more time in group than individual. And now that we're virtual, it's 4 groups during the day instead of, I guess, 6 or whatever it previously was. 2 of those more shorter groups that are a little bit more community meeting style, where we build rapport and act more as a community, which we have gotten anecdotally is really therapeutic, actually. And then 2 more of those skills intensive groups. The difference between in-person and virtual is that virtually we have the luxury that we don't have to pull a patient out of a group because there is a lull in between group times. So that's when we can see more of our patients and spend more time with them. On average, it's probably a 30-minute session for individual work. Could be anywhere from 20 minutes to an hour, but generally it's around 30 minutes or so. And that's about as much as kids can tolerate us, if I'm being honest.
Thank you. One of the questions that I have, and I've been talking with families a lot, is about self-injury and also lack of functioning. So a student might not be in crisis per se, but at what point, I think families, sometimes it changes day to day. So at what point would families reach out, and what might they expect with someone who maybe isn't at high risk of suicidality or needing like a crisis response, but just overall functioning is not great. Maybe they don't have a provider. Is there a quick and fast way to get students some help that are kind of in that place? We're seeing a lot of that now, that kids just aren't functioning to the way that their families have seen them. The depression is worse. There's more self-injury. So it's kind of those things I think are more exacerbated. Is there something that families can do to get their children help more quickly?
I guess I can take this. My recommendation would be to just call. I mean, I think that, crisis can be defined by, different things to different people. And I wasn't lying when I said, if you are concerned about your child, call your crisis team. That's the nice thing, is we obviously want to be proactive. We don't want to wait until that minute when, there's suicidal thoughts that are sneaking up. If, a child is struggling with self-injury, if you're noticing that they're more depressed and isolating, you can call crisis. They don't have to be suicidal. They don't have to be actively hurting themselves in order to reach out to mobile crisis. A good example is we actually had a mom call our team specifically yesterday, just wanting to give us a heads up that her daughter was being discharged from a inpatient unit. And they had recently moved to the area, and she wanted to make sure that, we knew, and that the youth was in our system, and kind of like to put her on alert and just say, she's being discharged. I'm just worried, and we might be calling. And I just wanted to make sure you have all the information now. And that's fine. I just always encourage parents, if you're worried, if you see a change, if, like I said, your teenager is isolating more in their room, it never hurts to have a clinician talk to them, to check in, to have an evaluation done. So, yeah.
Thank you so much. There's no more questions in the chat. I don't know if there's any other follow-up comments or questions.
Doesn't seem like it. I wonder, Kara, do you want to take it from here?
So I wanted to just close out our session tonight first by thanking all of the panelists for being here and sharing all of your knowledge and expertise with not just the families, but also us as clinicians. We're always learning, especially during the time of COVID. So thank you so much for that. And secondly, I just wanted to commend the parents who are here tonight who, were brave enough to come on here and listen to this information and be an advocate for their child. It's not easy, and we know that. So thank you for being able to do that tonight. The other thing I just wanted to share with families is that, our hope for tonight was not only to get you information that we know families need right now, but also to remind you that you're not alone and that there are many other families going through this. And that one of the reasons we run our parent support groups is so that we can connect those parents together so that you can be reminded that you are not the only one and you're not going through this alone. So I encourage you, if you haven't already put your email address in the text box, or if you can, I was just thinking about privacy, people might not want to do that. I have shared in the text box, the chat box, our flyer. So feel free to save that. We are constantly updating it. So it's always that link. And I did want to just sort of leave you with a quote about, the value in those parent support groups and the value in others supporting us. So the quote is, "Sometimes we need someone to be there with us, not to fix the problem, not to offer advice, not to do anything in particular, to simply be present in what we're feeling, to show up and acknowledge what we're going through and hold a supportive, safe space to us, to be with what's showing up for us." And I thought that was a really great quote to sort of summarize what it is that those groups offer for parents. So with that being said, I just want to thank everybody again for being here tonight, and have a wonderful evening.